Mrs. Milton also mentioned bed occupancy. I took part in a hospital redesign recently. We built our new hospital. And one of the overriding criteria, which was underlay the whole phenomenon of hospital design, the whole philosophy of PFI, Private Finance Initiative, is you can have what you've had. In other words, you can't use the PFI process, you can't use the process of redesign to provide yourself with something that's much better than what you had before. Leading, of course, predictably to the usual rows where we're sitting around, all the clinical staff are saying, well, we want to move to a hospital that's based on single rooms only, whereas, of course, the financial envelope would only cover the same mix of 6s, 4s and a few singles that we had before. So I work in a hospital that was constructed, 5, 6 years ago, and we have the majority of our patients in 6-bedded and 4-bedded bays with almost predictable effects on the rates of C. diff and MRSA infection and all of the other hospital-acquired infections that we see. I don't really see that process changing or that philosophy changing, whatever happens, whatever governmental changes there are, as long as, of course, we've got the same emphasis on spending restrictions in the health service as we currently have today. I would very much like to see a complete change in the hospital building notes, but I'm not quite sure it's going to come. So what are the research priorities I think we need to look at? I think there are some areas where we really need to provide good, solid evidence, where at the moment we have perhaps a commonsensical approach, perhaps something which just seems appropriate, but which we can't really demonstrate is working. We need to look at the evidence behind the effectiveness of educational and behavioural interventions. I mentioned care bundles, there's some good evidence for those, but can that principle be extended to other areas of practice? Is there good evidence about the way that we can actually educate staff and the way we can achieve behavioural change? The evidence base isn't strong at the moment. It also isn't very strong in fact in things such as bed occupancy. All of the evidence on bed occupancy is actually retrospective. There are no prospective trials. I can imagine it would be very difficult to do. There is nothing beyond retrospective association type evidence. And so although I can stand here and say, we all said we should have single rooms, we actually didn't have any evidence for it at the time. It seemed like common sense, but we didn't have the evidence to back up our assertions. We need to look at the effectiveness of environmental decontamination. I heard about one hospital that's had all of their door plates stripped out, made their brushed steel door plates stripped out and replaced with copper, because this is thought to have a greater antimicrobial and antiviral effect, so that every time you open a door you push against a copper plate. It's an interesting one, but is there good evidence to support it? And if there is, should we do it throughout the entire health service? That's the sort of question we need to be asking. We also need to ask about the role and the effectiveness of screening methods. I sit in a clinic every week where I assess the patients who are going to be having caesarean section over the following week, and I have to tell all of them that as well as the various blood tests we're going to recommend, they also have to have an anti-MRSA swab stuck up their nose so we can see if they're contaminated. It is very difficult to resist the feeling that when they say, well, what will you do if it's positive? It's very difficult to resist the feeling, I should say, well, we'll just take you out back and dispose of you by burning. Fortunately, as far as I know, in the 5 years I've been running this clinic, we've never found any patient who's actually MRSA positive coming into the hospital for a caesarean section. I've no idea what we'll do if we do. So, how can we pull all this together? We need this research, I think, and we need it, unfortunately, for arguing for a good research base, we need it at a time when rates for the headline infections do seem to be coming down. We do seem to be taking some effective action at the moment, but I think that's the time to invest in research rather than to throttle back. And that's because this is a journey. The whole thing about control of infection is a journey that doctors and indeed all clinical staff want to go on. To persuade people to go on, we need the research base. The health services have to move down this road. We have taken the first steps, but I think some of the things I've outlined are about how our perceptions and feelings as clinical staff are that the first steps have involved an over-reliance on measures, on short-term measures which have caught the headlines, like the alcohol hand gels that I mentioned to the Prime Minister, and like the dress codes that were implemented by Fiat a couple of years ago. And at the same time as these headline measures, which may or may not have an evidence base, we have a relentless focus on activity in the National Health Service, a relentless focus about pushing patients through, about keeping occupancy rates as high as we can, about hotbedding patients through units so that we can get them out of the emergency department within the 4 hours, and so forth. And that sort of activity focus is completely at odds with what we see as the rational basis for control of infection. What we need to do is to deepen the research base in order to have an essential prerequisite to knowing what we need to do and to engage staff in those measures, and also, and perhaps most crucially, to persuade governments to pay for them. Thank you.